The following program is brought to you by the Center for Educational Outreach at Baylor College of Medicine.
What I wanted to do today is talk a little bit about some practical management issues in regards to Down syndrome. And just a little bit as a reminder, Down syndrome, as many of you probably know, is one of the most common chromosome problems that we deal with in the medical practice. It's approximately 1 out of 650 to 800 live births. So it is the most common chromosomal abnormality in humans, and most of them are caused by what is known as Trisomy 21 that you may have heard of many times because it's the most common cause for Down syndrome. So there is an extra chromosome 21 that causes the clinical problems associated with Down syndrome. A small percentage of Down syndrome individuals have what is known as a translocation form, and although this is relatively infrequent, that's why all children born with Down syndrome have a chromosomal study, so we can look and see whether there is trisomy 21 versus a translocation form. And just as a reminder, Down syndrome for the medical practice is a relatively new disease. It was back in 1930 that a doctor, Dr. Vanderbilt, suggested that Down syndrome may be caused by a chromosome problem, but it wasn't until 1959 that it was really uncovered as being the cause for Down syndrome. So imagine that we only have 50 years at 2009 that we know what exactly is causing this problem. And in terms, for medical terms, this is a relatively new disease, so we are learning a lot about it. And for some of you that may be familiar with this picture, this is a picture of a chromosome or a karyotype, a chromosome study, and you can see that down here they're like free structures. Those are chromosome 21, and normally there should be 2 of them, and in this case there are 3 of them, and this is what is called trisomy 21. So this is the karyotype of a male that has Down syndrome, and say male because you have the chromosomes, the X and the Y chromosome. The next picture, this picture is a little bit different. This is sort of a variation of a chromosome problem, and this actually happens to be a translocation between chromosomes 15 and 21. This is an unusual situation. This will be a normal person that is a carrier for this translocation, and even though this person is healthy or wouldn't have any problems, but this person that has these chromosome 15 and 21 together, when having children, may pass it on, and that will be someone who carries a translocation that may result in Down syndrome. So I don't have to introduce to this group what Down syndrome looks like, and this is a very cute child that has Down syndrome. And child Down syndrome has some facial features that makes it more recognizable to us as physicians, and we typically pay attention to some of these features. But needless to say, these are fairly normal looking kids, and they don't have any major problems or any major diseases. We do have to deal with certain medical issues that we will try to cover over the next few minutes. And the more significant problems are related to their development, to their growth, and also initially to the low muscle tone. And as I mentioned before, there are some facial features that may help us with the diagnosis, but they don't necessarily are considered medical problems per se. In terms of clinical issues, and that's some of the issues I want to touch upon tonight, you have Just briefly, the congenital heart disease or the heart problems, and I'm not going to talk too much about this because many of you are probably very familiar. This is something that about 40 to 50% of children with Down syndrome may have, and is typically a structural heart problem that may require, in some cases, surgery, and once it's fixed, it's pretty much gone. But I'm going to spend a little bit of time talking about these three other topics, which are the intestinal problems, and in particular what is called the celiac disease. You may also have some additional gastrointestinal problems. One that may happen at birth is the atresia of the duodenum, which is basically where the stomach comes out, and that may be a little bit narrow and may require surgery. Or sometimes you can have Hirschsprung's disease, which is a condition that causes very severe constipation. One thing that I would like to talk a little bit about is the blood-related problems, and because people get very concerned when they hear the word leukemia. And the other condition that you may be very familiar with is the thyroid disease, and Down syndrome is associated in a large proportion with a slow-working thyroid gland, and that's something that your pediatrician is going to check fairly frequently. And lastly, the breathing problems and what is called obstructive sleep apnea. And obviously for us, for the physicians, and especially for the geneticists, we deal with a number of questions that are kind of listed here. When a child is born with Down syndrome, one of the first things parents ask is, what is the diagnosis, what cause, what's going to happen in the future, what are the treatments or the options, how we, what we can do to help these kids, and definitely what is going to happen in the next pregnancy. And in terms of the diagnosis, obviously it's going to be the clinical plus the chromosomal studies, and the cause I briefly talked to you before about this trisomy 21. With regards to the future and the treatment, that's something that we are learning more and more, and I'll like to share some of the things that are important in terms of follow-up or lifetime, treatment. And in terms of the recurrence risk, although it's probably beyond this talk, by most part is relatively, if you're dealing with trisomy 21, the recurrence risk is low and is typically associated with the age of the mother, but is approximately around 1% in most cases. So that's a relatively low recurrence risk. In terms of what the American Academy of Pediatrics has recommended, there has been some problems in translation between programs, so I apologize, it doesn't look quite nice. But basically what this is a table that shows the things that pediatricians will check in terms of health care with all Down syndrome children, and there are some things that will be especially a little bit more carefully looked at, like the thyroid gland, looking for hypothyroidism, looking at the echocardiogram initially to look for heart disease, the blood counts to look for hematological problems, etc. But all of these are very clear recommendations that have been given by the American Academy of Pediatrics that allow the pediatricians to do a fairly good follow-up of your children. In terms of management, and these are the things that I will like to touch upon, the gastrointestinal problems and the issues related to apnea and the blood problems. And for the rest, I'm going to let, Dr. Maduri is going to talk more about the behavioral aspect that you probably will be very interested in hearing about. So one of the things that we have seen over the past few years that has become more common recognition is the issue of the sleep apnea. The sleep apnea, or the obstructive sleep apnea, is when there is brief pause during the breathing, and that typically happens while asleep, and is also associated with some very specific symptoms. Snoring is one of them. Insomnia, the children with obstructive sleep apnea, because they're not getting enough oxygen, they're not sleeping well, they're very sleepy during the day, or they tend to fall asleep very frequently during the day, and sometimes even behavioral changes. Now we know that it's very, very common. Up to even 50% of kids with Down syndrome may have some degree of obstructive sleep apnea. And we know that the number of factors that contribute to this are the structure of the face, because the face tends to be a little bit flatter, the airway passage is a little bit more narrow, there is the low muscle tone, the tongue usually gets in the way sometimes, and that can be also worsened by large tonsils and in some cases obesity. So if this is left without treatment, can over very, very long period of time, and if it's severe enough, cause heart problems. But this has to be something very significant. What is done to treat this particular problem? Well, you basically need to improve the passage of the air through the airway. And if this problem appears, the first thing you do, you get an evaluation with an ENT specialist. You can look at the presence of these perhaps enlarged adenoids or tonsils. And an easy way to fix is just to remove them. If this doesn't work, another possibility is using something that is called a CPAP. So this is a machine that is used at nighttime that gives positive pressure through the nose or the mouth, and that opens the airway and actually improves the passage of air and oxygen. So the surgery certainly can help. There may be reasons why sometimes the surgery can have problems, and that's why the possibility of these machines to help with the breathing of the CPAP or BiPAP can help significantly. These are just examples of, these are like MRI site views of different situations where you have, this is what is called the lingual, these are the adenoids, and sometimes you can have a fairly low tonsil. So imagine all these different tissues, there are different areas in the airway, they are obstructing the passage of the air. Sometimes you can even have a very large tongue and you can have infiltration with fat. Sometimes you can even do surgery and take the adenoids, and then they may actually grow back. So there are many different possibilities by which you may have obstruction of the airway, but the truth is that your ENT and your doctor will help you figuring out and help you with the specific treatment. So the next topic I wanted to touch briefly is celiac disease. You may have heard celiac disease because it's relatively a common disorder, and we know that celiac disease is caused by a protein that is called gluten that causes damage to the gut or to the intestine. It's fairly common in the sense that you can basically see it in 1% of the population in most of the studies that you will see out there. But when you look at Down syndrome, now we know, depending on the articles that you read, and some articles put it up to 10% in the incidence of this disorder. So you can imagine you're talking about anywhere from 3 to 10 times more the incidence you will see, or the frequency you see in the general population. So what is the gluten? Well, the gluten is sort of a mixture of different proteins, and it's very commonly found in a number of foodstuff. many people that have celiac disease are checking constantly in the grocery store and checking on the packages because the gluten is very commonly found in a number of products that you will typically get in at the supermarket. But things like wheat, barley, and rye, they all have gluten. There are other things that can be safe, like oat, rice, and corn. So there may be an issue with contamination, but the truth is that once you can identify that there is a problem with celiac disease and related to gluten, the diet can be changed and can be significantly, the problem can be significantly improved. So what are the symptoms? What happens when you have celiac disease? Well, first, what you see is what is called malabsorption, meaning that the gut no longer can absorb the right nutrients, and that causes a number of things, that could result in poor growth, could result in problems with constipation or chronic diarrhea, sometimes with some abdominal swelling, and even sometimes it can be difficult to recognize because it could be fairly silent. And that's one of the things that now we recognize that has to be checked on Down syndrome individuals, because you may actually miss it fairly easy. And this is a slide that shows you the difference between, this is a piece of intestine that has been sort of cut very, very small, and under the microscope, this is what the normal intestine will look like. You see like these finger-like structures, and this is what the normal surface of the intestine will look like. So imagine all the nutrients that are being absorbed in all these different areas. So when you get a situation like celiac disease, all of these protrusions or fingers are pretty much gone. So you end up with a lot less surface to work with, and that can result in a number of problems and vitamin deficiencies, calcium, folic acid, and iron. And the number of studies, anecdotal studies on Down syndrome that has been written in the 60s, in the 70s, that indicate vitamin and nutrient deficiencies in Down syndrome. There are many people out there too that offering all these vitamin therapies, claiming that there is a deficiency in nutrients and vitamins again in Down syndrome. So now we know over the past few years that this is a problem that we can diagnose and that we can treat. So no longer you have to be careful about some of these claims, and no longer you need to assume that Down syndrome is associated with vitamin deficiency, and that's what it causes, or some people imply that this is what is causes the problems associated with Down syndrome. So how do you check for it? Well, there is a blood test that you check, that we do, that can detect up to 95% of this problem, and that's an antibody. That's just a chemical that is in the body. It's called transglutaminase. So this is something that you can ask and your pediatrician can offer, and that's a fairly simple test that can be done at the same time that you're getting the thyroid check. If this test is abnormal, if there is a problem, and then the next test to do is just to take a small piece of the intestine, and you do a biopsy, you confirm, and then you put your child on a gluten-free diet. And after the gluten-free diet, the things are definitely going to improve. So the last health issue that I wanted to talk about today, so I can let Dr. Maduri go on with her presentation, is the blood-related problems. And it's also why I mentioned this, because there's always an issue that concerns the families a lot. One of the first things that you hear when the diagnosis of Down syndrome comes up is the possibility of leukemia, and that scares the families significantly. And we know now that there are a lot of blood-related issues that can appear in Down syndrome. Early on, many of the kids with Down syndrome may have an increased number of red cells, and that's something that it happens a little bit, more common than in the regular newborns. But that's something that will fix by itself. What we also know is that there is a problem with the immune cells and the immune functions, and that is associated because of there are some abnormalities in the cells, the T cells and the B cells that are present in the Down syndrome individuals. You know that the white cells mainly are formed by what is called the T and the B cells. The B cells, they make the antibodies, and the T cells are the ones that fight directly with the infections, the viruses and bacteria. And we know now that approximately most of the T cells are decreased on the first few years of life, and then they tend to normalize as the children reach the adolescence. But the other cells, the ones that make the antibodies, typically remain low. So this is something that is typically associated with increased number of infections. And that's also why children with Down syndrome and individuals with Down syndrome have more infections, respiratory infections and other infections compared to their peers. With regards to these rare conditions, there is one that is called Transient Myeloproliferative disorder, that it's a fancy word to explain a sudden raise of the white blood cells that you can see actually is fairly common in Down syndrome, and up to 10% of children with Down syndrome may develop this transient elevation of the white cells. By most part, it clears in the first 2 or 3 months of life. And now we know there is a lot of technical detail in this slide, but now we know that there is a genetic instruction on chromosome 21 that it appears to be directly related to this particular process. So the excess of genetic information on chromosome 21 is what appears to cause or to lead to this particular process. But again, the majority of times, this is something that will go away. Some of these children will end up having leukemia, but again, it's only 1 out of 200 children with Down syndrome. So this is, even though it's much more, is higher, is much more increased than in the general population, is still only 1 in 200. And the one thing that you should know that the leukemias on these kids are very sensitive to chemotherapy, and it appears to be actually the way that they are treated are differently. They're lower dose, they have a very good response, and because of that they seem to be more sensitive and they have higher complications from the therapy. But now it's something that can be managed relatively well by, the hematologists are very well aware of this type of treatments and disorders. So a couple of words about other treatments, the treatments for the future and research. One of the things that some of you may know or not is that there's a lot of research going on in Down syndrome. And in fact, in the scientists, what sometimes they do is they try to replicate diseases or models for a disease or a particular medical problem in different animals. And actually, there are 2 different mice that have they have been experimentally created and to mimic, what you will see in terms of genetic information in Down syndrome. And interestingly enough, these 2 strains of mice that have been studied, they all seem to have defects in what is called synaptic plasticity, and that's something that is giving the researchers some clue that there is something going on in terms how the brain cells are connected and how those connections are working. So because of these advances, the number of drugs are being tested, the number of things are being looked at, and there is a lot more hope that comes just from understanding some of this basic process, because you obviously can access some of these animal models, you cannot do experimentation in humans. And this is just to remind you that the body is just full of these nerve connections, and these nerve connections appear to be very significant when it comes to problems like in the case of Down syndrome. And this is just sort of a cartoon of the elemental part of a nerve cell or a neuron, and it has all the different connections. And now we know that this connection and these synaptic endings may be, which are the areas where the cells are connecting with each other, may have a significant clue as to what's going on in Down syndrome and in many neurological disorders. So this is sort of a cartoon that shows you what these connections between the neurons are like, and this is something that is called the synapse. The synapse is what connects one neuron with the next, and you have a number of chemicals that are going through one end, and they're being transferred to the next cell, and that's how communication ensues and how it occurs. So we know that these information, these biochemical compounds that go through the neurons, and how this biochemical information transfer from one place to another appears to be critical for, again, a number of neurological problems. And this is maintained by a number of processes, and one of them is the cycling of this material and these biochemical compounds, that they are sort of put out and sometimes reuptake or sent to the next cell for communication. So, and we know that there is the way that the cells mature, the cells grow, and the neurons grow is very dependent on these particular processes. So, just to give you an example, there is a protein that is called Synaptojanin that is one particular biochemical compound, an enzyme that is on chromosome 21. So the instructions for this particular element are located in chromosome 21. And this is, for example, a biochemical compound that is very critical for normal cycling of these elements, these biochemical elements, in this particular case for acetylcholine, which is one of the biochemical compounds that is being put out in the neuron. So what happens, or what is believed, that if you have an excess of this particular element, this particular biochemical compound, the synaptojanin, what you have is more of these, there is more recycling, and there is less of these biochemical present in the nerve endings. So one of the ideas behind it, and some of the treatments that are being looked into it, is that if you can reduce the levels of this particular biochemical compound, you may be able to allow some of these chemicals to stay more time where they should be, and therefore cause some improvement in some of the symptoms. So this is just to point out some sort of research that comes from animal models, and may actually the number of drugs are being worked on just to see if some of these biochemical compounds can be modified. What I'm trying to say or to show you is that a lot is really coming up. A lot is being right now researched on. there's a lot of, pharmaceutical drugs, and there's a lot of, research and basic research that is giving us clues as to what to do and how we're going to be treating children and other patients with Down syndrome. So this is a new disease. 50 years, again, just as a reminder, is what we now has passed since the time Down syndrome was discovered, and we knew that this was caused by trisomy 21. And now, at this time, we are now finding out about all the genetic instructions in chromosome 21, how they contribute to the medical problems. And what we learn along the way is fairly significant, and I have no doubt over the next few years it's going to be a lot more going, and even a number of interesting treatments and possibilities. So just as this is a summary, the number of things that in the meantime that you can look at, the sleep apnea, the celiac disease, some of the blood cell-related issues, of course, the thyroid screens and all of those things that you're probably already familiar with. But there's a number of things that are coming along the way that I'm sure are going to be very promising. I think I'm going to stop here, and I want to acknowledge the Down Syndrome Association of Houston for making this crowd possible, and also to the Title V grant and the Texas Department of Health, and especially to Susan that has done a fantastic job to put all this together. I will take questions at the very end if you have any. Thank you very much.